Hi, I'm Dr. Tom Field, and in this video lecture, we're going to talk about behavioral overcontrol. We're going to talk about both obsessive compulsive disorder and eating disorders in this context. It's a bit controversial, perhaps, to address both of these in one video lecture. They're not often thought of as being similar diagnoses, but I think through the lens of behavioral overcontrol, they make sense. And so that's why I'm going to address them together here. So we're going to talk about obsessive compulsive disorder, obsessive compulsive personality disorder, hoarding, trichotillomania, excoriation, and body dysmorphia. You may remember that we saved over obsessive compulsive personality disorder from last week. We will also talk about anorexia nervosa, bulimia nervosa, and binge eating. These have cross-cutting symptoms to them, okay? And that's why I'm including them in this video lecture together. Both of them have some degree of underlying anxiety, OCD, and eating disorders. Overcontrol behavior is used to cope in both. In OCD, you see compulsivity, as well as perfectionism and micromanaging in OCPD. In eating disorders, you see restricted eating and purging, okay? The compensatory behaviors themselves become the targets of intervention. They become their own problem. Compulsivity, things like restricted eating, those can become quite significant, and not just the anxiety, but then the behavioral response, that becomes the target of intervention. Okay? Note that controlling behavior is a very common response to anxiety for all of us. If we feel anxious, we may trend towards being controlling of our environment to feel less anxious. It's another behavioral response to anxiety. Note that we have already talked about behavioral response to anxiety in the prior lecture. We talked about, for example, avoidance in order to control anxiety. We talked about clinging behavior in order to avoid anxiety. And so we're going to talk now about controlling behavior. From a biopsychosocial model, the biological kind of factor here is an activation of the sympathetic branch of the autonomic nervous system. Right, that a person has cortisol and adrenaline in their system, they feel more tense, more anxious because of that. And you often do see, by the way, in eating disorders particularly, some degree of family stress, whether or not it's like an authoritarian family or, you know, a family where there's like a high expressed emotion level or even sometimes some degree of abuse. That can be fairly common to eating disorders. And so there is some degree of stress there, okay? Psychological, you see factors that include obsessive thinking, compulsivity, and overcontrol. And I'll also mention here, probably even more than with the anxiety cluster that we looked at last time, there are some social components to these social factors to these diagnoses, particularly eating disorders. There's a lot of social messaging around body shape and size, particularly for women. And so that's part of the reason why you see a much higher rate of eating disorders in women is all of the expectations around body size, shape. And that plays into the expectations around body size and leads to things like the thinspiration movement, which only exacerbates eating disorders. We're going to first take a look at obsessive compulsive disorders. So what is OCD, or obsessive compulsive disorder, F42? It is considered to be obsessions, compulsions, or both, so you only need one, that are time-consuming or cause distress or impairment. Okay? Obsessions include recurrent, persistent, intrusive, unwanted thoughts, urges, or images that cause anxiety or distress in most individuals. Okay? The person doesn't want these thoughts, but they're there and they cause anxiety. They are anxiety-based. And so the person has to do something to compensate for them. They also have attempts at ignoring them or suppressing them, often by neutralizing them, such as compulsive behavior. So again, there are anxious worry thoughts that are there, obsessive anxious worry thoughts that are very strong, and they try to mitigate them. And the worry thoughts are typically around something bad befalling someone else or themselves. It can be things like, I'm worried about the health of a family member. right? Or I'm worried about my own health, or I'm worried about someone breaking into my house, or those types of things are pretty common. Okay. Compulsive behavior includes repetitive behaviors or mental acts that an individual feels driven to perform where rules must be applied rigidly. Okay. So what I mean by this is a person may, for example, lock their door 4, 5, 6, 7 times before they leave. They may um, make sure that they wash their hands very, very frequently. Now, of course, during COVID, this is kind of complicated, but outside of COVID, this would be more of an unusual kind of behavior. These behaviors or mental acts are meant to prevent or reduce anxiety, though at times they feel disconnected. Now, what I mean by this is if you have, say, a fear of germs and you wash your hands frequently, there's a connection there. It makes sense. But there are other forms of compulsive behavior that don't make coherent sense, such as I'm going to tap my foot 5 times, every few minutes to prevent a family member from, befalling ill health, right? There's no direct connection there. So sometimes the compulsions, they're not quite delusional, but, it definitely does not have a clear connection to the anxiety. Okay. A person may have different levels of insight into their obsessive compulsive behavior. They may have good insight or fair insight where they're aware, yes, okay, this behavior isn't helpful to me and I need to probably work on it, but it serves the purpose of making me less anxious, so, it's hard to give up. They may have poor insight where they're minimally aware of doing these repetitive behaviors. They may also have absent or even delusional insight. And that would look more like, if I tap my foot, then it's illness is not going to befall a family member, and I have no awareness really that that's a problematic thought, or do you know what I mean? That thought doesn't make rational, coherent sense. Okay, and in fact, I may have a delusional thought that it's absolutely true. Like if I stop tapping my foot, something bad will happen to them. I cannot stop. Okay, so what we'll note here is that there's anxiety in the picture, and the person deals with their anxiety through compulsive behavior. I'll very quickly mention here that all of us are a bit compulsive. Okay, here's a couple of notable examples. If you've never watched a baseball game, I recommend doing it just one time. Watch what the batters do at a baseball game, right? They tap the mound a certain way. They twirl the bat around a certain way, and then they're ready for the pitch, right? And the thought is, if I don't do my rigid ritual, then I'm not going to hit the ball, right? We all have these weird rigid rituals like that. But hopefully they're not, in the context of trying to mitigate anxiety. So there's the difference there, is if we're doing these just to mitigate something bad happening because of our anxiety, then it becomes more problematic. Okay, and if it's persisting, if it takes up a large proportion of the day, I'll also add here that with OCD, it can take up a lot of time. People can spend hours and hours in their compulsive rituals. Okay, let's next look at obsessive compulsive personality disorder, F60.5. This is a separate disorder than OCD. This is marked by a preoccupation with orderliness, perfectionism, interpersonal control at the expense of efficiency, flexibility, and openness. So it sounds like OCD, but it is quite different. Okay. So with OCD, it's largely internal to the person. They have their anxiety and they're doing these compulsive behaviors to mitigate it. With OCPD, they're also anxious, and the way that they mitigate that is controlling the people around them and their environment. They tend to be rigid and stubborn. They're preoccupied with rules, lists, order, procedure, organization, and schedules. A person who lives with them may be unable to deviate from that. No, there's a schedule. We must follow the schedule. There's a procedure. We must follow the procedure, right? And they're very, we might call them anal. They have perfectionist task completion, right? We must complete this task before moving on. They can be workaholics at the expense of leisure or friends. They may have a miserly spending style to hoard money, right? Be very controlling around money. They may have difficulty with delegation unless their directions are strictly followed. And they may be overly rigid about morality, ethics, and values. That, again, there's only one way of doing things is the way to think about this. Okay. So whenever you hear stories about a person whose house is spotless, meticulously clean, and who berates the children for moving anything in the house, that's more OCPD, obsessive compulsive personality, than it is OCD. Because again, it's controlling people around them, controlling their environment in response to anxiety. Whereas OCD would look more like a person, cleaning the same type of spot over and over again, because if they don't do that, something bad will happen. So it just has a different flavor to it. Okay, there are other disorders within the chapter that we should cover as well. Hoarding, trichotillomania, and excoriation. Hoarding is marked by a difficulty discarding items regardless of value. Discarding items causes distress. Their accumulation clutters and congests living space. And the specifiers with excessive acquisition, which is most people who are diagnosed with hoarding disorder. And again, insight is similar to OCD. What I'll note here is that anxiety also drives hoarding, believe it or not. If you ever interview people who have a problem with hoarding, they'll say something that goes along the line of, well, I don't know when I'll need this next, right? When I'll need these things, so I don't want to get rid of them because I may need them. There's an anxiety around, I don't want to get rid of things that I may need, right? I'll add here that you often find hoarding problems among people who have been homeless before, who haven't had a lot of resources, right? And there's some anxiety around that. Okay, trichotillomania next. This is recurrent hair pulling resulting in hair loss. It can lead to feelings of shame around this because a person can have bald patches in certain parts of the body. And this looks like more, compulsive behavior, but it's not in direct relation to the anxiety. It feels different. It feels more like an impulsive type of action. And then we have excoriation, which is kind of like trichotillomania, except it's skin picking. This actually can be very problematic because it can result in lesions. And I've worked with children before who've had excoriation problems, and they've had problems like MRSA in response. Okay, I have to share with you a couple of images for you to visually understand some of these things, like hoarding, like trichotillomania, like excoriation. And I have to give you the trigger warning that these images are not easy to view. And so if any of these are uncomfortable to you, you can skip a couple minutes of the video. For some of you, this will be helpful, though, to have a visual of what these things look like. This is an example of hoarding. You can see in the top image there's hardly any room to walk or move around, right? The whole room is covered, wall to wall. On the bottom left, you see another example. It's very difficult to navigate the kitchen. There's stuff everywhere. Same on the bottom right. What I'll note here is that if you look, especially in the bottom left, there's a lot of trash there, right? You could even make that argument in the top image as well. Newspapers, trash, things that people don't actually need, but they may feel like they need them, and it makes it hard for them to get rid of. Here's another example. You can see, again, there seems to be a lot of what looks like trash there. Okay, this is an example of trichotillomania. You can see there's a very large bald spot, right? That occurs because of all the hair that's been pulled. This is an example of trichotillomania occurring at the eyebrows. You can see eyebrow hair removal occur with trichotillomania. This is an example of excoriation. Excoriation, you can see here, it leads to lesions, right? To large areas of skin that have been picked away. This is an example of a nail that is subsequent to excoriation. Again, you can see problems with infection and such when this occurs. Okay, let's talk about body dysmorphic disorder next. This one's a complicated one. It kind of borders the line between OCD a little bit and also between an eating disorder. So this is preoccupation with perceived flaws in physical appearance that are unobservable or seem slight to others. A very common one is the nose, that a person may perceive themselves as having an unattractive nose, a flawed nose, that others probably don't even notice, right? It's not something they think about. Oh, that person had a weird nose. You don't really think about that during the day when you're around other people. At least I don't. In response to this, the person develops repetitive behaviors or mental acts connected with this preoccupation. For example, they may apply a lot of makeup, or they may have nose jobs, maybe a series of nose jobs, right? Or they may think about their nose a lot and be like, oh, they're looking at my nose. They're really thinking about my nose right now. Okay. Notice that this appearance preoccupation is different from an eating disorder. It doesn't lead to restricted eating behaviors, but it is about appearance, which kind of borders the line between, right, an OCD, an obsessive compulsive problem, versus an eating disorder. You will also see some men, particularly those women as well, have muscle dysmorphia, which is that they are obsessed with the way that their muscles groups you know what's the word that I'm looking for? Just a muscle tone looks, and will work very very hard at gyms to develop that, and be kind of obsessed about the way in which their muscles look, and they have again a preoccupation about it, and somewhat of a sense of insecurity around muscle. Okay. Same insight as with OCD, good, fair, poor, and absent delusional. So what do you do about OCD, right, and those related conditions we've looked at? So with prevention, we'd provide psychoeducation on learned behavior and rituals, just like I talked about earlier, how a lot of us have these, but they can become very problematic if they're repeated to the extent that we're not even aware we're doing them, or they take up a lot of the day. Okay. Hygiene with hoarding, right? How can you make sure that even if you're going to keep these things, that you're not keeping too much, to the extent that you are unable to navigate your environment, and you may, have germs and such that develop because of this. And in general, a person is not going to get rid of all of their stuff if they have a hoarding issue, but they may be able to get rid of some of the things they've accrued, right? Body image with body dysmorphia, just talking generally about body image, developing an acceptance of how one looks. Mindfulness with trichotillomania excoriation, can they become aware, mindfully aware of the picking, so they can stop it? And intervention and treatment. I'll note here that these issues can be tough to change. And I've worked with clients before who have said that they wanted to change, say, the depression, but not the OCD, right? And the reason it can be tough to change is that it's reinforcing. It's like avoidance with anxiety, right? If you avoid the anxiety, you don't feel it, so it's very reinforcing to do it. With compulsive behavior, if you feel less anxious when you engage in these compulsive rituals, it's very difficult to move away from them because they fundamentally work, right? Here are the things we do to work through them if the client was willing. We would do cognitive restructuring around the worry, try to address the obsessive thinking. Impulse control, that we would help the person to be able to tolerate, right, not going to their compulsive behavior right away and just sitting with the distress and anxiety that engenders. We'd help them to self-monitor more and use exposure protocols to face their anxiety head first, especially if it's around something like someone, breaking into the house. Maybe we would have someone not lock the door and just, sit with that for a bit, especially if they didn't live in a dangerous neighborhood when they left the house. Existential, the meaning of anxieties, right? So, for example, if they are anxious about, let's say, a family member or something like that, what would happen if the family member had a health issue? Why, can we explain why you're worried about that? Explore that a little bit. And kind of, again, meaning making sense of the anxiety, digging into it a bit. And then psychodynamic, insight-oriented approaches. So, for example, where do these things come from, right? Why are you worried about, say, a family member or your own health? Where does that come from for you? Okay. I'll note here that the insight-oriented approaches of existential and psychodynamic really only work if the client has fair insight, at least. If they have absent or even delusional insight, those things are not going to really move the dial, right? Because there's no clear connection for the compulsive behavior to the anxiety. Medication is also a consideration for moderate and severe OCD, especially. Antidepressants are the most commonly prescribed. And so not that you need to be recommending a specific medication, but if you have a client with OCD and they haven't tried medication before, it should at least be presented as a potential treatment option. Okay, let's talk about eating disorders. Here are some clinical tips with eating disorders. Again, I mentioned that often parental overcontrol can actually be one of the major triggers to this. If there are controlling family dynamics, if there's a high expressed emotion level, and if there's trauma, those things can lead to the development of eating disorders. Note that medications do not fully treat eating disorders, same with trauma. They're conceptualized as a cognitive and a behavioral condition, and therefore CBT is one of the gold standard approaches to eating disorders. They usually require specialized training to properly manage and treat because of medical complications. We'll talk about some of those as we go. Okay, let's talk about race, ethnicity, and gender just for a second. Of eating disorders, anorexia presents the most substantial medical risk because it's tied to low body weight, and that differentiates it from bulimia. What I'll mention here is if you look at the rates of anorexia as well as bulimia, there are definitely differences by race, ethnicity, and gender. They are most common among women, and particularly women who are white. And we talked previously about how there are some social cultural constructs around that, around body image. Okay. Note that bulimia and anorexia do share some similar symptom patterns. Okay. Anorexia can be superimposed onto bulimia and vice versa. And so it's just worth taking a look at those symptoms and kind of clearly understanding the difference. They are often misunderstood, anorexia and bulimia. Anorexia, as you'll see, is also determined, the severity, based on body mass index, BMI. And the normal average range, if you will, for adult weight is 18.5 to 30. Okay, 30 is close to the overweight, is in the overweight range, but it's not in the obese range. And so anything within that range is not going to meet the criteria for an eating disorder. Okay, it's complicated, and I'll mention here that using BMI as a proxy for an eating disorder, is complicated. And maybe I'll talk about it now as to why that is. I've worked with clients who have lost 100 pounds in like 5 to 6 weeks. That's a huge amount of weight loss. And they've done it in a very unhealthy way. However, they are not at a low BMI. And so they don't qualify for anorexia. However, their behavior is definitely qualify for anorexia. So that's complicated. The other thing I'll mention to you is that a person's body shape and muscle tone plays a role in this. So if you're a person, for example, who is fairly muscular, you can actually have a higher BMI. And if you're a person who is fairly tall and slight, you can have a lower BMI just based on the height to weight ratio. What I will say, though, in general, based on my clinical experience, is that while I think concerns about BMI are valid, typically you do not see a person in the BMI range of less than 18 who doesn't have an eating disorder. That's very, very unusual. Typically, when you get into that kind of range, particularly as you go into the even lower than that, the 17 BMI, 16 BMI, there's no way really you'd have that without an eating disorder typically. Okay, let's look at anorexia nervosa first. There are 3 criteria. You need to have a restriction of energy intake and low body weight. Okay, a low body weight does matter with anorexia, and that's why you use BMI as there's basically a way to measure whether it's mild, moderate, or severe. Okay, if you have a person, again, who has lost weight or who has just the other criteria, B and C, without low body weight, they do not meet criteria. They more have something like unspecified eating disorder or bulimia. The person has a fear of gaining weight. This is the anxiety there, and behaviors that interfere with weight gain, right? This is the restricted eating. They also have cognitive distortions, right? How the body weight and shape is experienced, self-evaluation based on body weight, and lack of recognition of seriousness. They may, for example, look in the mirror and perceive themselves, as having a higher weight than they actually are. Just their own visual perception, right, can be altered. I'll note here that B is behavioral and C is cognitive. Okay, so you need to address both the behaviors that interfere with weight gain as well as the cognitive distortions in eating disorder treatment. There is 2 types, restricting type and binge eating purging type. Note that there is a binge eating purging type. Many of you just think about that as a feature of bulimia, but it is a feature of anorexia as well. The specifiers are in partial remission and in full remission. Note that if a person does not have a low body weight anymore, they're in partial remission. But to meet full remission, they also have to work through the behavioral and cognitive signs. And what I have seen happen in therapy is that B and C are actually harder to make major progress on over time if they even if low body weight does kind of get raised and it gets to a normal level, because working with clients who have, for example, been out of eating disorder treatment for a while, they can still struggle with their distorted thinking about their own weight and what a healthy weight is. In terms of severity, I mentioned BMI. A BMI of less than 17 is for mild anorexia, moderate is 16 to 17, severe is 15 to 16, and extreme is less than 15. Again, you're not going to see these types of numbers in people who do not have eating disorders. Okay. Oh, before I show these images, I should also mention to you that I need to share with you a couple of images next that are, again, unsettling. And so you can skip through the next several minutes of video if as needed, if this is too much for you. But it is helpful to understand what people may experience, their perceptions, if they have an eating disorder, and what kind of signs you'd be looking for when working with individuals. Okay? So here's the first image. You'll notice the way that a person perceives themselves in the mirror, and then the way that they present actually on the left-hand side, right? A person may perceive themselves visually as very different than how they actually are. Next, we have two images of people who have anorexia, okay? Note the way that they are thin. They are often thin in the thighs particularly, right? And in the upper arms. Sometimes it can be very difficult to assess for something like an eating disorder just by looking at the face. It may look slightly gaunt, but it is typically things like thighs and arms that clue you into anorexia. And those things are covered up by clothing often. So it can be difficult to actually assess for anorexia. And I'll mention that ahead of time to you, right? That if you're trying to figure out, okay, does this person actually have a low weight problem? It's difficult to assess for. One of the best ways that you could potentially do that is, again, you want to be coordinating with medical professionals, and it would be a good idea for a person, if you are indeed concerned, for them to see their primary care physician and to get a basic read of BMI and such. Okay, those aren't things that I think are great for counselors to do. I think those are better addressed by medical. And with, we'll talk about this in a few minutes, with anorexia particularly, you're going to want to consult with medical professionals a lot because of the medical concerns in the case. Let's talk about the neuroscience of anorexia. Anorexia is associated with volumetric reductions and atrophy in the anterior cingulate cortex. Remember, that has to do with one's own awareness, emotional regulation, and the cerebellum, which has to do with movement, and as well as emotional processing. Increased volume in the somatosensory regions linked to bodily sensations and mental representations of body image, right? Almost over, you can call this like overactivation there, which causes some of the perceptual changes. The right amygdala appears to be overactive, with alterations to food reward sensitivity and disgust, okay? And so that also changes the way we approach food, right? And a lot of clients you work with will have a lot of disgust around food, which makes it difficult to consume food, right? In terms of medical risk, low body weight is associated with an elevated mortality rate. It actually can be a life-threatening condition. And so because of that, you do want to take anorexia very seriously. Death can occur due to heart complications attributed to malnutrition. The person is at elevated risk for fractures because of low bone mineral density. Basically, the way to think about this is if you have not enough nutrients going into the body, right? Vitamins, but also energy stores, etc., and it's not producing things like bone regularly, you're going to have problems. You can see reduced estrogen levels in women, and amenorrhea can occur, which is the absence of menstruation. You can see underproduction of leptin and dysregulated thyroid function, and reduced adipose or fatty tissue and depleted energy stores, which in an adolescence can slow down pubertal maturation. Okay, so really significant effects of starvation. Let's talk about bulimia nervosa next. So for bulimia, you need at least once a week for 3 months binge eating episodes or recurrent compensatory behaviors, purging. Okay, binge eating episodes include, all the things you might imagine, and there's actually in binge eating a good description of what binge eating is. We'll get to that in a minute. The person feels a lack of control during the episode. With the purging, the compensatory behaviors, there is different forms of that. There's self-induced vomiting, which you're probably most familiar with. There's also use of laxatives, diuretics, fasting, and exercise. Overuse of exercise is becoming more and more common in clinical practice, at least I've seen that. Self-evaluation is unduly influenced by body shape and weight. So for example, when I look a certain way, I feel a certain way, I feel good about myself if I'm a low weight. If I have put on weight, I feel terrible about myself, right? The self-evaluation is very strongly influenced by that. And then you have the same specifies in partial and full remission, okay? Note that there is no low body weight in bulimia nervosa. That differentiates the two. It's not even though there are medical complications, and I'll share with you some of them in the next slide, which again, has some grisly stuff in there, but it's important for you to see visually. The person is not at low body weight, and they don't have the same medical risk to their life-threatening risk. Severity is the number of purging episodes per week: mild, moderate, severe, and extreme. And you can see here that, if you'll get engaging in at least one episode or more a week, you have moderate to severe bulimia, depending on the number. So yeah, here's the grisly stuff. You see bile decay teeth, right, in bulimia. That especially if they're engaging in the kind of self-induced vomiting, that bile reaching up into the mouth does decay enamel, and so it will cause dental problems. Okay, let's talk about binge eating next. So what is binge eating? In short, it is bulimia without the purging, just binge eating, okay? Has to occur at least once a week for 3 months. It's episodes of binge eating that cause distress. The criteria, as I mentioned, do have helpful descriptions of what a binge eating behavior is. So it includes eating more rapidly, eating until uncomfortably full, eating large amounts when not hungry, eating alone due to embarrassment regarding intake, and feeling self-disgust, depression, and guilt afterwards. Now, all of us, again, do a little bit of this. I think about your Thanksgiving roast, right? We all pig in a little bit, dig in and then feel terrible afterwards, like, oh, I really overdid it. But I guess the difference here is that probably doesn't happen for you every week, right? That's probably just in discrete events. So to meet the criteria for this, you need to be doing this fairly regularly, okay? And then you have in partial remission and in full remission. Here are the number of episodes per week that would be required for the severity type. So what do you do to address eating disorders, right? What's the best forms of treatment planning? So in terms of prevention, education matters about nutrition and healthy body weight. And nutritionists are often used, particularly in anorexia, so you'd be consulting with nutritionists. Body image. With children, I've done things like had them lie on the floor and had another child or an adult kind of draw around their body, and then they can draw around the body to show what they perceive their body to actually look like. Things like that are helpful to talk about the difference between perception and reality. Societal images of beauty, doing things like having a series of fashion magazines and looking at them together and cutting out images that display people looking a certain way and talking about that social construct can be helpful. Mindfulness, yoga, and body acceptance, helping a person sit in the body a bit. That's why yoga can be so powerful. In terms of intervention and treatment, most approaches use some form of CBT, as I've mentioned. For the cognitive part, you want to change the distortions around body image, body size, and healthy food intake. For behavioral, you want them tracking body weight and using food intake logs. This is always tricky because a person is already a bit obsessed about things like weight and food intake, and some clients actually don't like this, don't like tracking. So if they're not going to track, at least you want them to be exposed to it. One of the things that's often used in eating disorder treatment programs is the meal, which is everyone sits down and they have to eat a meal with a certain amount of calories, and the adult, the the counselors are sitting down and eating meals with the clients, and it's uncomfortable for the clients. They don't love eating that because they feel disgust with the food, but they're kind of pushed to do it. So it's that kind of exposure work that often can be helpful during treatment. In terms of family therapy, you would want to address things like overcontrol, right? And acceptance of the person no matter what, so they don't feel like they have to present a certain way with family, and for the family just to be in general supportive. By the time that a person has developed an eating disorder, oftentimes the eating disorder has become its own problem, and so even if you are able to improve family dynamics, the eating disorder may persist. You also can address any underlying trauma if that's a factor in the case. As I've mentioned before, coordination with nutritionists, medical professionals can be very important, especially with tracking weight and such in anorexia. That's not really something that you're best prepared to do. It's something that would be best addressed by medical. I'll note that some medications are prescribed for eating disorders, and you'll see this happen in clinical practice. In my mind, eating disorders are a cognitive behavioral condition that requires counseling. But there are medications that are sometimes prescribed, and I feel kind of mixed about them. Perceptual distortions that appear delusional are potentially a candidate for antipsychotics. You should also know that antipsychotic medication causes weight gain. Some prescribers actually prescribe it because of the weight gain. They want the person to gain weight. What I caution you about here is that just track a client who's on an antipsychotic if they have an eating disorder like anorexia, and make sure they're not gaining the weight too suddenly, because that can actually stop them from taking the medication, right? Or could make their eating disorder accelerate. You can also see antidepressant use for associated anxiety and depression at times. Okay, so some concluding thoughts about OCD and eating disorders. Behavioral overcontrol is difficult to treat. A person might make progress on things like depression but persist in their OCD or eating disorder. Compulsive and restricted eating behaviors serve a function that's hard to replace. The function is, of course, being able to control anxiety, and that anxiety is not easy to replace, to work through. Okay. With restricted eating behaviors, of course, it's also about wanting to be a certain weight and having perfectionism around that. And again, they have to be able to sit with being at a higher body weight and with the discomfort of that, which again is not easy to do. Perceptual distortions and illogic are uncommon. For example, touching my nose 5 times will keep my family safe. I look 20 pounds heavier than I actually weigh. And so you cannot always engage with the client from a perspective of logic. Sometimes you just have to entertain the idea that their thoughts aren't logical. And so you just have to target instead, like, okay, can we still get you, to be gaining weight? We work on that. Or can we get you to be touching your nose less often, right? Rather than talk about all the reasons you might be touching your nose. Anxiety is often an underlying condition, not always, but often is. Note that the behaviors themselves become the target of intervention, as we've mentioned before, and medications can be quite effective for OCD particularly, and should be at least considered as a treatment option at times. That wraps up this video lecture.